Today, Oscar, myself, and Hannah will be discussing the management of acute skin trauma.
The vision statement discussed how to lessen the risk of complications. They talked about how that there had been a drastic change in the last 50 years. Management of acute skin trauma by athletic trainers are limited in the literature, so that's why this position statement is important to be able to dive into all the literature that is out there. Each of the recommendations that the position statement provided had literature for each recommendation, and those were each graded based off of the SORT grading system. They were graded mostly B and C, and there were about 6 categories with 42 specific recommendations within the position statement, and they discussed cleansing, debridement, and dressing techniques. The biggest thing that they talked about was traumatic injury to the skin, and they talked about how it's common among athletes participating in all sports. They can sustain injuries such as abrasions, avulsions, blisters, incisions, lacerations, and punctures.
Problems athletic trainers are experiencing is unreported skin trauma, inappropriate wound management, which can result in delayed healing, cross-contamination, bacterial buildup, and infection. Overall, it can affect the health and playing status of the patient. One of the many recommendations from the position statement to provide proper wound care management is cleansing. So cleanse as soon as possible after acute skin trauma. Irrigation is a great way to remove any debris or dirt around the wound. Showering is also a great source of cleansiness. Hydrotherapy such as whirlpool can help hydrate the injury. Normal saline should be used, potable water, and avoid tap water. Avoid scrubbing or swabbing because it may be ineffective and reduce bacteria and damage the tissue.
Recommendations for debridement have the numbers 12 through 22. For the 12th recommendation that was in the position statement, it talked about thoroughly cleansing and debriding the wound. The area of trauma should be thoroughly cleansed and debrided before the dressing is applied. For the 13th, it was to continue until it is very well vascularized. Debridement should be continued until it has a healthy granulation or epithelial tissue is exposed. For the next one, the method of debridement should be based on the type of wound, amount, and type of debris, training and expertise of the healthcare provider, and cost-effective and time effectiveness of the technique. So that's when it comes to method of debridement, should be specific. For the 15th one, irrigation can serve as an extension of cleansing for debridement of superficial to full thickness abrasions, avulsions, blisters, incisions, lacerations, and punctures. For the irrigation, the pressure should range between 4 and 5 psi, and you should avoid driving debris and contaminants deeper into the puncture wounds, and irrigation pressure to 2 and 4 psi. The 16th one is talking about hydrotherapy debridement. It's telling us to avoid it because there could be a risk of cross-contamination. It's also not cost-effective or time-effective. For our 17th one, for wet to dry debridement, that should be avoided because the tissue removal is non-selective and painful. On the 18th one, we talked about, or it discusses wet to moist may be used. Care should be taken to protect healthy granulation to tissue. So that goes for superficial to full thickness abrasions, avulsions, blisters, incisions, and lacerations with the formation of a scar. For our next slide, for our 19th recommendation, talks about scrubbing and how it should only be used for superficial to partial thickness abrasions, avulsions, blisters, incisions, and lacerations contaminated with large quantities of small debris such as sand, grass, clay, asphalt. For the 20th recommendation, it discusses the conservative sharp debridement, how it can be used after cleansing to remove loosely adhering devitalizing tissue from superficial to full thickness abrasions, avulsions, blisters, incisions, and lacerations. For the next one is chemical debridement. So that's for debris that's such as sodium, hydrogen peroxide, silver, etc. Those should be avoided because some elements and compounds may damage viable tissue. And then for our last one for debridement is talking about autolytic debridement for postoperative incisions, superficial to full thickness abrasions, avulsions, and lacerations, superficial to full thickness blisters after removal of the necrotic roof with the conservative sharp debridement, superficial to partial thickness punctures, and autolytic debridement should be avoided with infected wounds. And so essentially those should be used for selective proteolytic digestion of necrotic tissue. For the next set of recommendations is under dressings, and so this will go over recommendations 23 through 27. So after thorough cleansing and debridement, an area of acute skin trauma should be covered with an appropriate dressing until fully healed. For the next one, it's non-occlusive dressings can be used as dressings with certain wounds. Clinically infected abrasions, avulsions, blisters, incisions, and lacerations and punctures, such as punctures with cavities, superficial, linear lacerations and postoperative incisions, superficial to full thickness abrasions, all the other injuries that I explained before, but with wet to moist debridement, and then superficial to partial thickness abrasions, again with that whole list of injuries I said earlier, but with punctures added to that list, and temporary dressings. The next one is superficial to partial thickness abrasions, and the whole list, and punctures on irregular body areas. Then for our 25th one, occlusive dressings should be used as primary dressings with specific wounds. And then for number 26, occlusive dressing should be used as a primary dressing with specific wounds. So superficial to partial thickness, partial to full thickness, partial to full thickness, and clinically infected abrasions, avulsions, blisters, incisions, and lacerations and punctures are included within this recommendation. For number 27, films and hydrocolloids can be used as a secondary dressing. And that is to provide impermeability to microorganisms, improve adherence, and promote a moist wound environment for superficial to full thickness abrasions, avulsions, blisters, lacerations, punctures, and traumatic and postoperative incisions. And that'll be an important one later on when looking at our articles.
Recommendations for infection and adverse reactions. Let's go over some definitions. An infection is a compromised disruption to the dermis, epidermis, or subcutaneous tissues caused by bacteria. This is the most common cause of impaired wound healing. An adverse reaction is from materials used to treat acute skin trauma. This occurs from the application of debridement or dressing material used. And these are some signs and symptoms of infection and adverse reactions. Some examples would be inflammation, warmth to the skin, fever, edema, erythema, wound dehiscence, delayed healing, and some severe indications would be vesicles, bullae, pustules, necrosis, ascending lymphangitis, and regional lymphadenopathy. For recommendations of infections and adverse reactions from the NATA position statement is monitor the wound area for infection, fever, pain, edema, erythema, warmth, wound dehiscence, and delayed wound healing. And they also referred back to the NATA position statement of skin diseases for treatment of bacterial infections. That would give us a reason how to diagnose, treat, and go for return to play protocol. Reduction in infections can be done by cleansing, debridement, and dressing techniques. Skin antithesis is recommended to reduce surgical site infections from incisions and lacerations. It is also recommended to use oral antibiotics if needed if the infection is heavily contaminated. Topical agents can be used to prevent infections and monitor the patient from adverse reactions from topical agents, solutions, and dressings. The recommendations continued would be the patient's health status could contribute to adverse reactions. The AT staff would monitor the patient for adverse reactions from the treatments. Treatment of adverse reactions consists of finding the cause, removing the cause, and solving the tissues of the reaction. Recommendations for referral. In most instances, acute trauma to the skin does not require referral because they are often treatable by the athletic trainer. However, in extreme instances, referral may be required. Recommendations for referral or where referral may be required would be deep wounds that require tissue approximation with sutures or staples, heavily contaminated wounds, wounds with nerve or tendon injury, delayed healing, allergic reaction from the treatment, adverse reactions such as erythema, warmth, edema, pus, or pain inconsistent with findings, or immunocompromised patients. It is recommended to follow up with the patient, and the follow-up should include the athletic trainer monitoring the patient, the wound area, and the dressing application used for the healing process. The patient, and also it should be included to have patient education to increase compliance on dressing guidelines.
On supplies for AT facilities and kits is when it comes to facilities, normal saline and potable water should be accessible, a syringe when it comes to debridement, antiseptic skin cleanser, woven gauze, sterile scissors and tweezers, non-occlusive dressings such as woven, non-woven, sterile gauze, non-adherent pads, adhesive strips and patches and wound closure strips, and occlusive dressings such as allegiance, films, foam, hydrogel, hydrocolloids, and dermal adhesives, adherent tape, wraps, and miscellaneous supplies such as a biohazard container, bag, box gloves, face or eye shield.
So for my article for the current evidence section, they asked a clinical question: do rates of healing, infection, and pain differ depending on whether non-moist or moist dressings are used to manage superficial to partial thickness wounds? So within this article, they basically got different groups of patients with different types of wounds for different types of partial thickness wounds. And they managed it with either a moist dressing or a non-moist dressing. And during this time, while they were managing it, they took their pain scores and documented how many days it took them to heal. So for the moist dressing, they found out that it was good because they used a hydrocolloid and a polyurethane semi-permeable transparent film. And they found that it decreased days to complete healing and their pain scores went down a lot faster. And the biggest patch that they used here was the hydrocolloid dressing, and that is a moist dressing where I'm so sorry. It is a moist dressing and it was found to be the most effective. And so that is all I have to say on that one. So for the non-moist dressings, they found that it was increased days to complete healing and their pain scores took a lot longer to decrease.
In the second article that we found, it just furthered more recommendations. So take in mind bleeding times such as wrestling. ATs must be aware of the specific situation and make rapid clinical decision regarding whether to treat the wound temporarily, allowing immediate return to play, or to remove the athlete to repair and treat the wound. Also keep in mind any medication the athlete might be consuming. This will just give you a better idea of any signs and symptoms when it comes to wound management. Like we said earlier, avoid hydroperoxide because this will just damage the cell and delay healing. The article focused more on abrasions, laceration, and sunburn. So return to play when it comes to abrasions. They can quickly return to play as long as it's cleansed and covered properly. And lacerations, in some cases, the wound can be covered, protected, and can wait for repair until the end of the event. Sunburns. So when it comes to mild sunburn, they could be treated with cold compressions or rinse with cool water. Moderate can be treated with aloe vera, and severe sunburns can be treated with oral steroids and pain medication and cream.
For the third article we used, it was used by Wounds International with research from International Skin Tear Advisory Panel. They used a risk reduction program for skin, which would apply inspecting the skin and using any previous history of skin tears, and also using a protective clothing. For the general health, they used patient education and skin tear risk prevention on skin tear risk and prevention. They also used possible risks and reactions to medications from cleansing, debridement, and other things like that. Identification would be from the cause of the skin tear, the dimensions of the skin tear, the skin integrity, signs and symptoms of infection, the type of pain, and type of amount of exudate. They continued using tools and supplies such as dressings, gloves, tweezers, sutures, gauze. They used management to assess and control bleeding if needed, to cleanse, and follow up as needed. Goals were to treat the cause, avoid trauma, manage exudate, avoid infections, wound healing, and protect skin.
References and our discussion questions. Thank you.